Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, good afternoon. I'm Susan Kaufman. I'm here for Attitude Magazine's weekly ADHD Experts broadcast. Today we'll be talking with Dr. Theresa Regan about adult autism. Autism spectrum disorder is a condition that impacts people across childhood and through their lifespan. Although it's commonly regarded as a pediatric disorder, it in fact affects adults as well. Frequently, sometimes misdiagnosed as ADHD or other conditions. So growing awareness about autism has really led a number of people, including many people diagnosed with ADHD, to wonder whether they might be on the autism spectrum. So, and we hear from many of our listeners at Attitude who are wondering about the autism spectrum diagnosis. So today, Dr. Regan will be talking about autism and the facts and the myths about autism in adults, why getting a correct diagnosis at any age is really important, what the similarities and differences are between autism spectrum disorder and ADHD and other disorders that you might be interested in, as well as some of the diagnostic criteria and treatments for autism. So I think it's a timely topic, and we're really pleased to have Theresa Regan, Ph.D. here. She is a clinical neuropsychologist with a specialist in brain behavior relationships, such as autism spectrum disorder. She's worked with adults within hospital systems for over 30 years. She is a certified autism specialist and the director of the OSF Healthcare Adult Diagnostic Autism Clinic, associated with the University of Illinois Medical School and based in Peoria, Illinois. She is one of the rare neuropsychologists specializing in adult diagnostic of autism specifically, and the author of Understanding Autism in Adults and Aging Adults, as well as Understanding Autistic Behaviors, Improving Health, Independence, and Well-Being. So I refer you to her books, which I think you'll find helpful. Dr. Regan, thank you so much for joining us today.
Thanks. I'm really glad to be here. Yep, and
great.
Thanks to... Go ahead.
No, sorry. I just wanted to say that, as always with our broadcast, Dr. Regan will present her slides, and then we'll take as many questions as time permits. And before she starts, we'd just like to ask you to complete a brief poll. Specifically, what is your primary reason for joining today's webinar on autism? Is it for yourself? Are you seeking, or do you have an autism diagnosis? Is it for a loved one who might be seeking or have an autism diagnosis, or is it for your clients? While you're taking the poll, let me just take you through a few just elements of the webinar screen that you have before you. You'll be entering your questions in the Ask a Question section. Enter them at any time. We're looking forward to your questions. You can download the slides now if you click the Download Webinar Slides in the Event Resources section of the screen. If you want to learn more about today's sponsor, we don't actually have a sponsor today, but if you want to learn more about the expert speaker, click the tab just above the slide if you want to see her bio. If you have any audio issues, you can download our GoToWebcast troubleshooting guide from the Event Resources section of the screen, or click the question mark icon for technical help. Most audio issues, I should say, are caused by slow internet connection. So we recommend using Chrome if you have it, and a wired internet connection is really helpful, as well as closing any other programs or tabs to maximize your available bandwidth, and try refreshing the page if you have trouble. So with that, let's turn to the poll and see what the results are. Because we don't have the results yet. So let's just turn straight to Dr. Regan's presentation, and we'll come back to the results later.
Okay, sounds good. Welcome everybody who's joining us live and anyone who's listening at a later date. We are going to talk about autism in the adult and why getting a diagnosis can be complex and kind of confusing. And I always like to start off with a discussion about the myths about autism, and there are so many that we're just going to start with 5, but I feel like it gives us a good framework for talking about the topic and moving on to our other points of interest. So the first, as Susan said, is that the myth that autism is a childhood condition. So autism is a neurologic condition. It is based on how the brain is wired and the pathways and what they're doing. And it is a condition whose characteristics are first seen in childhood in the developmental period, but it is a lifespan condition. So individuals with autism as children will still express those characteristics in some way over the lifespan, and certainly the great majority of cases. So it's really important to understand that this is something that impacts adults and aging adults. The second is that individuals with autism don't have or want relationships. That's really a myth as well. What does seem to be the case is that individuals in the spectrum often have fewer relationships that are reciprocal. So they're kind of those that we share back and forth about topics with this person. They tend to have less relationships that extend across time and are maintained across context. So, those people that we stay really close with no matter what we're doing in life. So people tend to have fewer of those. But I would say about 80% of the people I work with in autism really do want to have some close connection. The difficulty ends up being that sometimes they really struggle to know how to start relationships, maintain them, understand them, and sometimes really tolerate kind of the ups and downs and roller coasters of normal relationships. Another myth is that autism is a condition seen in boys. And certainly research suggests that it's more common in males, and that's probably for some genetic reasons. But we're really missing a lot of the women in the spectrum. They have all the same diagnostic criteria, but they can present just a bit different. So we're really kind of missing many females. And the ratio as it stands now is about 4.5 boys diagnosed to girls and men to women. Boy, a big myth is that if somebody has autism, it will have been diagnosed as a child in school, in a pediatrician's office, sometime growing up, because the characteristics were present. And we're going to talk about why that's not the case. But that certainly is a myth that we have to dive into. And another myth is that somehow autism has to do with intelligence and other cognitive skills. And in fact, autism is really a condition of behavior and social connection. None of the criteria have anything to do with intellect. So you're going to see autism expressed across the continuum of intellect. And we really need to get better at recognizing what autism looks like across variations of intellect. So many people in the spectrum have really functional intellect or even very superior. So why is a diagnosis so difficult? Well, part of it is that as a culture, we're really still lacking in understanding that the brain impacts behavior and interactions. So we're much quicker to think that behavior is a reflection of discipline or will or a person's character or motivation, but we really aren't yet to the point where we understand that there's really a brain basis for temperament and some of the behaviors that we lean toward. So I think that we're very quick to feel that behavior is willful. Also, the diagnostic criteria for autism were not published in the DSM, the Diagnostic Statistical Manual, until the 1980s. And even at that time, much of what we knew about autism really was not complete. And so even in the 80s, it was hypothesized that this was a condition relating from poor parenting. And of course, we've come a long way to really understand the neurologic basis and develop the criteria better. But many people who are adults now and aging adults now were well through childhood by the time this was an emerging diagnosis. I think we've done really well at improving autism awareness in the sense that it's really hard to find someone who doesn't know the word and doesn't understand that it's a really impactful public health condition for the community, that it affects children and families. Where we're really lacking is autism recognition. And so even among medical professionals or mental health professionals, we're really not to the point yet where people can say, I know what autism looks like in my classroom, in my medical clinic. I know what it looks like in my family and in my neighborhood. And so that recognition is the piece that we're really kind of lagging behind on, and we need to improve. I really like to talk about the parable of the elephant when I'm talking about the complexity of diagnosis. And so I'm going to tell you the story of the parable, and then we're going to talk about how it relates to autism. So this is a parable that's over 2,000 years old, and it has a few variations across culture, but essentially the story is that there was a village that had never encountered an elephant before. So when an elephant was brought to the village, it was really this unique experience, and everyone flooded to the center of the town to see what an elephant was like. Well, there were a group of villagers who were blind, and so they weren't going to be able to see the elephant, but they wanted to participate. And they said, well, we can perceive what the elephant is like by going to stand around the elephant as a group, and we'll each put our hand out and we'll perceive through touch what the elephant is like. And so that's what they did. They went to the center of town, and the first person put his hand out, and he could feel the trunk of the elephant. And he said, oh, I know exactly what an elephant's like. An elephant is like a snake. That's what an elephant is like. And then the next person put her hand out and felt the ear and said, a snake, an elephant is nothing like a snake. It's broad and thin and willowy. An elephant is exactly like a fan. The next person was feeling the side of the elephant and said, oh, nothing like a fan. I have problems reaching the top and the right and the left. It's so broad. An elephant is like a wall. The next person felt the leg and said, no, an elephant is like a tree trunk or a pillar. The next person touched the tail and said, no, an elephant is like a rope. And the next person touched the tusk and said, no, it's hard and long and pointy. It's like a spear. And the lesson is that even though everyone was correct about what was right in front of them, they were really all incorrect because nobody saw the big picture. And really the big picture is what an elephant is like. It's like all of those together. And so what happens with autism is that often people come to my clinic with 5 to 7 diagnoses, and they're all labeling a piece of the bigger picture. So, for example, and we won't go through all the possibilities, but someone might come with a diagnosis of bipolar. And this is because they have had a history of emotional and behavioral dysregulation, so difficulty staying even and calm and appropriate to the context. Well, emotional and behavioral dysregulation is really core to autism as well. So the same person maybe goes to another person and says, oh, I also have trouble organizing and paying attention and have trouble with my time management. Well, that person says, oh, I know exactly what that is. That's ADD or ADHD. And so then they have a diagnosis of ADD or ADHD. But no matter how many people they go to and get all these different pieces labeled, nobody sees the big picture. So often I have someone who comes with bipolar, ADD, OCD, social anxiety, personality disorders, eating disorders, really a wide variety of diagnoses, but they're all kind of capturing a little piece without seeing the big picture. So what are the criteria? We're going to really skim through this so we have time for questions at the end, but I do want you to have a sense of what the criteria are. So there are 7 different criteria, and the first 3 that are listed here have to do with social communication and relationships. And all of these 3 must be present for a diagnosis. Social reciprocity has to do with the back and forth of social communication. So it's the ability to share thoughts and feelings and then to listen to what's important to the other person and really be aware of what's important to them. The next one is nonverbal social communication. It includes things like eye contact, but also things like personal space, gestures, facial expression, expression in the voice, and many different types of nonverbals. The third one is developing, maintaining, and understanding relationships. And often we're talking about those with peers. So it's common in the spectrum for someone to be more comfortable with people much older or much younger, but really have trouble connecting with peers, understanding and maintaining those relationships. The next 4 criteria, 2 of those would be 2 out of the 4, any 2, would be what's required for a diagnosis. The first one includes repetitive stereotyped movements, verbalizations, and use of objects. So this is a huge category that's difficult to dive into quickly. But if you've heard of stereotypies, they would fall in here, things that look like tics, repetitive movements like hand flapping, verbalizations like echoing yourself or quoting directly from movies or books. Use of objects would be lining things up, patterning objects, or handling them in your hands. The next one has to do with rigid behaviors and thinking. And this can be expressed with really concrete black and white thinking, like everything is either good or bad, very literal thinking, difficulties with abstract thinking, or difficulties with change. Something that's unexpected would be difficult to manage. The next is intense fixed interests or attachment to objects. So this could look like the person that's all in with a particular topic or hobby to the point where that's what they talk about all the time to other people. And the attachment to objects can have to do with collecting things related to the interest, or it could have to do with some hoarding or pack rat behaviors where the person's not willing to let go of objects that are no longer useful. And the fourth has to do with sensory processing. So it can be overreactivity to the sensory environment, which would be someone having trouble with lights being too bright or noises being too loud. Underreactivity, which would be the person that breaks their collarbone and doesn't really realize it's broken because there's not much pain. Or fixation on sensory aspects of the environment. So that would be a person that is really fascinated by watching water flow or a fan turn. So that would be just an unusual fixation on the sensory aspect. So let's move to the topic of ADD, ADHD versus ASD or autism spectrum. So both conditions really involve a lot of executive function deficit. So they're both conditions where the center and the front part of the brain are really impacting the symptoms and presentation. And I really never see an ASD individual without significant executive function difficulty. So one of the questions that we'll have to figure out as a community of researchers and clinicians and teachers and so forth is, if ASD is a big picture diagnosis, the elephant in the example, is ADD kind of labeling one part of the big picture separately, like saying the tail is like a rope. And I don't think we've quite figured that out. The DSM as it stands says that both conditions can be diagnosed. So if somebody has ASD and they also meet criteria for ADD, which is common, that they can have both diagnoses. I think the advantage of having both is sometimes that people helping the individual might understand how to help someone with ADD a little easier than they would know what to do for ASD. There are downsides, though. If stimulant medication are used in ASD, it is less effective, and sometimes it's just problematic. So sometimes patients will respond with increased anxiety, skin picking tics. They can get kind of that obsessive manic restless spike. And many people with ASD already have some restricted eating patterns, so to have appetite decrease for some people could be problematic. So it's not a good or bad, it's just a little complex. I would say about 20% of the people that I work with do seem to benefit from their ADD medication, but about 80% either don't feel benefit or feel uncomfortable. So we really want a good, accurate diagnosis for everyone, whether that's going to be ADD, whether it's going to be bipolar, whether it's OCD or any of these other conditions. We just want it to be really accurate. And one of the difficulties with ADD is that attention as a symptom is really general, like fatigue would be if you're going to your doctor. There's so many things that can cause attention problems that sometimes if the cause isn't looked into, things get missed. So it's very common for people to come to my clinic with a diagnosis of ADD, and then, we do a checkup and we see that, actually they have a learning disability and nobody's caught that, or they have sensory issues and they can't concentrate, or they have, these other things that have been labeled inattention, but really the person's struggling to make sense of their environment. So we certainly want to be as accurate as we can for all of these diagnoses and really investigate what the best diagnosis would be for each individual. So I've kind of set up the beginning talking about why it's missed and why it's important to really get diagnosed and have an accurate diagnosis. The difficulty, of course, is that as a culture, we're just catching up to this fact. And so there really are not enough places that you can go for a diagnosis. If you are seeking a diagnosis for yourself or someone else, I would say to look for someone who can specialize and see the big picture. So if you go to an ADD specialist who can't see the big picture issue, you'll be diagnosed with ADD. So if you go to a bipolar specialist and they don't know the big picture, you'll be diagnosed with bipolar. So I would say if you can find someone who could also see how all these symptoms go together, that would be great. And somebody who understands conditions across the lifespan. So in our culture, we have pediatric specialists and we have adult specialists and geriatric specialists. And there's a lot of benefit to having people specialize in these categories. The downside, speaking from someone who is trained in adults and aging, that, people who serve adults often don't know how to recognize a developmental condition appropriately. So someone who has lifespan experience would be good. I would stay away from someone who relies on a questionnaire cutoff score or a diagnostic or structured interview cutoff score, whatever it is. I use questionnaires and I use interviews and I use lots of things, but I would stay away from someone who relies on that one cutoff score. So we want someone who really knows the criteria and can gather information from lots of different sources. So even the questionnaires and the different instruments that are really helpful, they'll always say that they shouldn't be used alone. And the DSM also says that you really want to gather information from multiple sources and in multiple ways in order to see if the criteria are met. Another would be that I would just ask the person how many diagnostic assessments they've done for adults. I find that it's becoming more common for people's websites to advertise that they provide services for autism spectrum conditions for adults. But there's just a wide variety of how much they can actually do and how much experience they actually have. So I've run into some that really are well-versed and see a lot of people, and I've also run into some where people forgot it was on the website or they're not really sure who does that. So I would just ask how many. If someone's done 5 versus 50, that's good to know. I would also always ask for an explanation of what criteria are met and not met for you or for the individual. So a lot of people will chime in about whether they think the diagnosis is correct. But when I say, well, what criteria do you think are met, or what criteria do you think aren't met, I've never had anyone actually know the criteria, whether that's, even a specialist. It's just very rare for people to know what the actual criteria are and what they would look like in an adult. So I would just ask, if somebody says, no, you're not in the spectrum, I would ask them what criteria aren't met for you. So why have a diagnosis? Why is it important? Well, first of all, throughout the lifespan, it's going to be impactful. And I really didn't realize this until maybe the last 10 years. I kind of thought that as long as people were doing okay in school, whether they had a diagnosis or not, may not be that impactful. But I really can see the lifelong impact, and I feel like it's very important to establish a correct way of describing what the person needs and what they would benefit from. And I know that working in a hospital system, the doctors really need to know if someone's on the spectrum. It helps us provide better care. It helps us know what their nutrition might be like. It helps us know if they might be able to call our office with a question or might avoid that. And as people age, we're getting people in our memory disorders clinic who come with memory issues, and it turns out that actually they have an undiagnosed autism spectrum condition, and we really need to know that when we're diagnosing dementia. So we want to do no harm. We also want to make the strategies just very specific to ASD, and there are many strategies and pieces of advice that I would give for someone in the spectrum that I really wouldn't think of for any other diagnosis. Third, the community supports and services for developmental diagnosis versus mental health diagnosis, at least in our community, are separate. So if you have a diagnosis of ADD and bipolar, you'll be served by the mental health arm of support services. And if you have a diagnosis of ASD, you'd be served by the developmental services. And it's important to know that you're getting the services that would best match what your condition is. It helps people understand what appropriate expectations for improvement might be. So a lot of times with spectrum behaviors, there's a lot of shame and blame and frustration about why isn't this person changing. And so we really need to understand, so this is a neurologic condition, and these are things that we could really work toward for improvement. These are good goals. But also we don't want to shame someone for not being somebody that they're not. And so we really want appropriate expectations. And self-knowledge. So for the person with ASD, I think many times they're really on a journey to figure out what makes them tick and why they see the world and experience the world the way they do. And they want to be able to communicate that to other people and say, hey, this is what I need, or this is why I had that reaction. So that really arms the individual with an important tool. There are some specific interventions, and we're not going to dive into these really deeply, but you'll probably hear things like social skills and relationship training. Behavioral strategies will be really based on what behaviors are present, but they're going to be informed by neurologic techniques and things you would do for neurologic behaviors. And then emotional regulation strategies. So as I said, it's very difficult for someone in the spectrum to really keep an even sense of calmness and centeredness. And some people will present with fight patterns when they get overwhelmed. So they may have meltdowns or outbursts. They may have really extended arguments with people. Other people may show flight behaviors. So they might leave a job, leave a relationship. They might leave the room. And other people may show freeze behaviors. So someone that's physically present but really not mentally there. They've kind of shut down and maybe even expressed their sense of being overwhelmed through even a physical symptom, like a neurologic spell or what might look like a seizure. So we really want to give appropriate strategies there. And in the spectrum, I like to use sensory inputs to calm and center the body. So I like to use proprioceptive inputs, which is deep pressure activities through the joints. Deep pressure, you might have heard of weighted blankets. That's kind of that concept. And for some individuals, they seem to benefit from vestibular inputs. Those are movement inputs. And sometimes even other sensory systems, like people might have a scent that they find calming. So those are really the points I wanted to get across today. And then I just wanted to make sure we have time for questions.
Thank you so much, Theresa. That was fascinating. I wanted to revisit the question of diagnosis. There are a number of people asking for a little more clarity on how a diagnosis is made. For example, are there questionnaires that are used? Are there online quizzes valid? Could you talk a little bit more? You said the process of diagnosing autism spectrum required a number of different methods, and I wonder if you could just clarify a bit more what a good diagnosis is comprised of.
The reason that questionnaires and online quizzes can't be used alone is that it's really difficult to capture each way that those 7 criteria could be met. And so what I do is I do use questionnaires. I like the social responsiveness scale. I use the adult-adolescent sensory profile for sensory issues. I just also have developed different questions in my own interview. And I always interview and assess the patient, and then I always have family or somebody to corroborate and give their perspective and their point of view. I have found certain questions to be particularly helpful. I always like to ask the person to explain how other people would describe them. So it's nice to see if they have a sense of how they impact other people and how they're viewed. I also like to ask how one person that they know well might describe them differently than another person. I find that their ability to understand that people experience them differently is often problematic. I go through just all kinds of questions related to each criteria. So the questionnaire is one resource for me to understand if the criteria are met, but I would also need to ask questions related to all of the other criteria that aren't asked about on the questionnaire. So I always have the criteria right in front of me, and then I use the questionnaires and some of my standard questions. I do role play with people to see how they do with conversation. I have some pictures of emotional faces. I try to see if they can determine what emotion is in the face. I have some social scenarios, and I try to see if they understand what would be rude or polite in that kind of a setting. So really, the diagnosis should be made from the criteria, and you should use questionnaires or online quizzes as kind of a screening or jumping off point to see if you can start to see this picture emerge, and then to look at the criteria and really see what other information you would need to know. And it's tough because the criteria can be met different ways. So, for example, you could take the person who comes on too strong with other people, and they're described as very social because they'll go up to anybody and talk to anybody, but they're talking kind of indiscriminately and not appropriate to the context. And then they might be talking about their special interest. So, they'll talk to anybody about aeronautics, but it's not really reciprocal. It's not a back and forth. But another person on the spectrum might not approach anyone. And so you need to know what extremes might fit into each category. So it's complex enough that it's not doable with one cutoff score, but I think that all those sources kind of feed whether the criteria are met. And that's why you need someone experienced enough to navigate the criteria.
Okay. I'd say there are 3 or 4 people listening in who are wondering whether it's worth pursuing a diagnosis given the complexity and in some cases the cost. So here's a person who says that he was diagnosed with bipolar a couple of years ago, but he's always felt that he was on the spectrum. His 3-year-old child has an ASD diagnosis, and many of the same sensory and sort of fixation issues. So he's an example. Should I pursue additional testing for ASD for myself, or do you think it would change my therapy or medication plans? He's not the only person. I've cited, given his example, but others have said, I just don't know whether at this point in my life it's worth going through what it will take to get a good diagnosis. In your view, what are the advantages or not?
I think the practical questions are really important to think through. And I think there's not a one-size-fits-all answer. I get to see the benefits, but I do think that for people where the cost would be really a strain, and they have a good sense of what to do to help themselves regulate because things are working and they have a child on the spectrum and they just know, I would say I would probably feel comfortable putting that off. And then if there's an issue where you're getting a workup and for something, and again, I just work a lot with the dementia clinic, but let's say you're getting a workup later in life, and as long as you tell them that you've always suspected that you have features of that or that you meet criteria, at least they would know then. They'd have a flag. Another time when it's important is if it affects your medical care. So a lot of my patients have very restricted eating profiles, and we really need to know that. So I had one patient who was undiagnosed but had a son who was diagnosed, and she was a diabetic. And I saw her for something completely different, but it turns out all she was eating were mashed potatoes. And that's really important to know. And so I think if you're somebody who has enough self-awareness already that you could know what other people need to know, and you don't have an agency requiring you to report. So you're not asking for formal accommodations at work, or you're not, seeking a job coach or assistance with disability, then I think it makes sense to defer that. But I would just make sure that you're trying to think through who might need to know that and then communicate it. And then if it becomes really important later, you could pursue it later.
Right. Speaking of cost, I mean, in your experience,
Yeah.
does insurance cover adult ASD testing? And do you have a sense of what the cost might be?
There's a lot of variability with that, but yeah, the people that come to our clinic are people whose insurances will support that, and so I think it's not something that's off the table, but the difficulty is finding someone experienced enough to do it, risking that you'd go in to get assessed and the person's not that experienced and doesn't really see it. And maybe there's a portion that you would have to pay, or you would have to pay it all. So I think all those things are really important, that everybody thinks about their life. But what I would say is just if you could have enough self-awareness where you could kind of express some of that to someone if they might need to know.
Okay. Yeah, it seems that there one of the listeners in is saying that their HMO refused an autism assessment, stating that we won't give you an assessment because it wouldn't change your treatment plan. This is a person who's being treated for ADHD medication. So that may be something that comes up with insurance, companies.
I mean, it should change the treatment plan, but I do think insurances aren't as savvy about the differences that it would make.
Right.
But yeah.
Okay. One question that comes up fairly frequently, and I know that DSM no longer recognizes it, is Asperger's. What is it that we used to call Asperger's, and how do we see, I guess, high functioning ASD today?
That's a big question. So, and in the United States, we're not using that term. In other countries, they may still be using it in certain places. I think it's a fine way to describe things in people. I like the way the diagnosis is now because I feel like it. One of the problems, again, this is just a complex topic, but one of the problems with the concept of high-functioning autism, I don't like that word because we confuse. High-functioning only relates in most people's mind to intellect and cognition. And so we call people with functional intellect, high-functioning or Asperger's, but intellect is not part of autism. So I have people who are brilliant and yet really aren't functional. They're living in their parents' basement and they're not working, and their life is just very small. And so, that person would be called high functioning. I think there's lots of good resources with that term on it. Asperger's, I think if people like books about that topic, and you feel like it fits you well, that in the United States, we just cut down on the number of terms that were fitting into the spectrum. So instead of pervasive developmental disorder and autism and Asperger's and some other that you could include, now we've made it ASD, and then you specify the particular individual profile for the person. So, this person has these characteristics and these strengths and weaknesses, but I really get concerned when the severity of the autism is described by intellect because they're not, they just don't overlap. So I like the way it is this way better, but I love a lot of resources that use the term, but I kind of like separating that concept.
Right.
So
It's not an IQ issue.
right.
It's right. Got it. Listeners are pretty aware of the kinds of medications that are often prescribed for bipolar or for ADHD. But they're wondering, are medications prescribed for ASD
So
in general? Turning to treatment to some degree here now. Yeah.
Right. There are, always ongoing trials about that. But typically there are 4 categories that someone may take medication for in the spectrum. And one is the attention and executive function. That's the one I find to be a little bit the most, trickiest as far as whether it's tolerated and whether it helps. But ADD medications are a common one to try in the spectrum. The second category, besides attention and executive function, has to do with sleep. So sleep is not part of the criteria, but it's a very common co-occurring difficulty. And oftentimes when it's present in the spectrum, the person will have a real significant difficulty falling asleep, and they may be a night owl, and they may be up till 2 or 3 in the morning and sleep into the day. So sleep is also a symptom that's commonly prescribed if needed. So that would range from, talking to your doctor about melatonin to sometimes clonidine or trazodone or those kinds of things are used. The third category, often where medication might be recommended, would be mood and anxiety. So anxiety is really a very physical part of autism where it's just so core, and it's a brain-based, body-based generation of anxiety. And mood for depression, it's not as core to the spectrum per se, but of course there are many obstacles and life seasons that may be difficult. So depression would be common as an overlay. So SSRIs and those kinds of medications, so things like Zoloft or Prozac or different things recommended by a doctor might be prescribed. And then, hopefully it would be one piece of kind of helping to tone down those difficulties. And the fourth area that medication can be prescribed for is outbursts. So if somebody has a more explosive presentation, or then sometimes antipsychotics or different things could be used. And again, that's a generalization. But the other thing is that we're finding that about, and the statistics vary a little bit, but about 10 to 12% or maybe a little more of people in the spectrum will have 1 or 2 psychotic episodes. And so in those cases, antipsychotics would be used as well.
Right. Okay. There's a mention here of ABA therapy and a person who believes she would benefit from that. What is ABA therapy? And outside the medication realm, what are the common therapies for the non-medication therapies for autism? There's a big question for you.
Yeah.
Yeah.
Yeah. So there's different. There are different things that could be pursued outside of the spectrum or outside of medication. So ABA therapy is applied behavioral analysis, and it's a therapy that's been found to be helpful, certainly for kids, as far as using reinforcements and thinking about what precipitates the behavior, what behavior do you want to see, and then having a reinforcement kind of situation. So they apply techniques based on those principles of reinforcement to help with different activities. So it could be that the child is reinforced for using words instead of pointing to something, or they're reinforced for a social behavior. I think that there's applications for ABA in adulthood. I think it's a little bit harder to map that out for an adult in the sense that the same type of simple reinforcement may not apply as much, but I've seen it used for people who are needing someone to help them create some discipline and structure in their life, and kind of putting in the structure and reinforcement strategy in for them. So that's one kind of therapy. Social skills therapy for adults often would be, sometimes there are social skills groups in communities. Sometimes an individual counselor would do social skills training, and that's often helpful. And it's kind of, I kind of feel like it's teaching an adult to speak a new language, where a lot of progress can be made with social skills, although the individual might still feel like it's difficult to really be fluent in that. But you could certainly do the social skills. And sometimes it's counseling related to other issues like the management of anxiety or marriage issues or relationship issues for the partner to really understand why the person reacts a certain way, and for the individual to understand what the partner needs. So I see the social skills and the counseling piece a little bit more than the ABA for adults in our community, but I'd be interested to know if it's being used more. I know that different companies are trying to roll out more of an adult plan for that.
But social skills training would be one of the main forms of intervention then for ASD, as I hear what you're saying. I understand that it depends on the person, right?
Yeah, social skills training, and then sometimes helping people with their emotional regulation and also with adaptive behavior. So adaptive behaviors are independent behaviors. So if somebody's struggling to really have a good daily routine and get their hygiene done and leave the house and get a job and that kind of thing, sometimes a reinforcement strategy or counseling for that can help improve independence.
Okay. Do you see in your practice a difference in ASD between women and men? There are some women who are wondering whether their types of symptoms are different than those that you see among men who are diagnosed with ASD. Yeah,
I definitely do. Sometimes what I see is that the women tend to have a little bit larger range of emotion in their face and voice. And they tend to mimic social standards better than some of the men that I work with, so that they're really taking on personas or they're mimicking the person that they're with. And sometimes they do it fairly well, but it's exhausting and really stressful to try to mimic what's going on around you. Sometimes I feel like I would say about 50% of my patients, their special interest is a little bit more socially relevant sometimes than some of the men tend to be that I work with. So maybe they'll jump into church work as their special interest, or environmental causes, or and so sometimes it can get missed because of that. But when you actually talk to people, they'll say, "Oh, this person's actually very obsessive about it," and really noticeably kind of diving into the one topic. A lot of times, at least for some of the young adult women I work with, they can find the drama of other female peer relationships really overwhelming and not enjoyable. Sometimes they might gravitate more to being friends with guys, or so that can be a piece of things too. And sometimes it presents with an eating disorder. So I think the statistics now are that about 20% or a little bit more of females with anorexia are actually on the spectrum.
Really? That's interesting.
Yeah.
So it's associated with, eating disorders.
Yeah, so sometimes their special interest might be nutrition, and then they become obsessive. And also in the spectrum, people can have really restricted, repetitive eating profiles because of sensory issues or because they really seek repetition. So it can be kind of overlooked because they present with the eating disorder as the most critical thing. So I see that in women more. They also often, have a history of being at risk for trauma in relationships, like being taken advantage of and not realizing what's happening, that kind of thing.
Mm-hmm. Interesting. Yeah. An astonishing number of people listening in have posted about their experiences attempting to be diagnosed with great difficulties. Sometimes, refusal, sometimes not being told they were not on the autism spectrum when they feel strongly that they are, and vice versa. And I guess the questions that are being asked relate to both what kind of professional can best diagnose ASD, neurologists, psychologists, psychiatrists, and how to find that person. I'm guessing that you have said that it's a person with a great breadth of experience, probably more important than which type of profession. But do you have any comment on that question?
It's just an eternal frustration to find someone because there's such a great need, and as a culture we haven't supported that specialization yet. Really the reason that I'm diving into it is because I was an adult specialist who had a child in the spectrum, and so I kind of had that impetus and that drive to do that. Neurologists in our area typically are not specialists in it. Psychiatry, in my experience, haven't been very well versed in it. We're really just trying to get people educated on what flags they might see where they would send someone for assessment. So I'm not really even convinced that they would see the flags. Typically, psychologists should be the best first, but we're really not yet there. If people are really feeling like it's very common, I think, for people to be missed. And so I really feel for that, frustration. I would say if somebody says you're not, I would really ask what criteria aren't met and why. And if they're relying on a cutoff score, I think that's a problem. But then, of course, where else do you go? I mean, our clinic in Illinois, we are having people come from out of state, so I know that it's a very universal kind of challenge to find somebody. I don't think there's a simple answer now, but I hope that we're going to invest in that in the future,
Well, I can't thank you enough. This was extremely interesting, and I'm sure we'll be following up based on the number of questions. I wanted to repeat the names of your books so that people could find those. I think they sound like they'd be very helpful. And those are Understanding Autism in Adults and Aging Adults, as well as Understanding Autistic Behaviors, 2 books by Theresa Regan, R-E-G-A-N, Ph.D. And thank everybody for listening in today, and I hope you'll tune in to Attitudes webinars in the future. Thanks so much, Dr. Regan.
Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEmag.com. That's ADDITUDEmag.com.